Hi, my name is Dr. Jason Hawks. I am the co-owner, chief scientific officer, and investigator at the Oregon Medical Research Center in Portland, Oregon. And I'm excited to talk to you a little bit about what is generalized pustular psoriasis or GPP, and what do we know about treatments for this rare condition. So at a very high level, let's just talk about psoriatic disease. Within psoriasis, there are multiple different types of variants. We've got the common plaque psoriasis, probably about 85% of our patients. And we have much rare presentations, such as erythrodermic psoriasis, or even some of our generalized or even localized pustular psoriasis cases. The reason this is important is we know that the pathophysiology, while there's some overlapping immune mechanisms, there's some key differences. And we're going to use plaque psoriasis versus GPP as an example, both widespread generalized type conditions, but very different immunology. So in plaque psoriasis, we have more of an adaptive immune response. T cells, for example, really making high levels of IL-17. We know dendritic cells are making IL-23, and this is really the predominant signaling axis. So IL-23 and 17 signaling really driving that hyperinflammatory keratinocyte proliferation that's really driving the plaques, the scale, and the erythema. While we know that other immune pathways contribute, it's really going to be this central predominant pathway. Very much an adaptive immune response. A lot of gene mutations that are driving this in patients are really tied to those key pathways. Now, in contrast, we have GPP, which presents very differently. Doesn't really have the large plaques that we see, these well-circumscribed plaques in plaque psoriasis. But in GPP, we're going to see a very predominant pustular component. That's going to be the main clinical feature. So even though plaque psoriasis might get pustules here and there with neutrophils, really GPP is driven predominantly by these pustules, really characterized by neutrophils in the skin, in the stratum corneum, but also the epidermis, forming these individual pustules or these lakes of pus as they coalesce together and form these larger pustular areas. So these patients predominantly present quite different. They often have widespread erythema or background, almost erythroderma. They tend to get more desquamation or flaking of the skin with that erythema. And again, they're going to have these often very monomorphic pustules. They look very similar in shape and size. They can kind of coalesce together. But these patients should dramatically look different than our plaque psoriasis patients. And what's interesting is that when we look at the pathophysiology and the underlying immune mechanisms, we find a very different pathway than we see with plaque psoriasis. So rather than being IL-23, IL-17 based, we really see IL-36 driving a lot of this. And this is really part of our adaptive immune system, because unlike the T cell or our innate immune system, unlike the adaptive immune response in plaque psoriasis with T cells, we see keratinocytes, these cells really making high levels of the IL-1 cytokine families, which includes IL-36. These are really going to be the main signals driving the clinical features of GPP. So we see this high level of dysregulation with IL-36, again, predominantly made by our keratinocytes. And IL-36 has a very strong attractant factor in terms of bringing neutrophils into the skin. So no surprise that as high levels of IL-36 come up, we start to see recruitment of neutrophils into the skin, forming these pustules or these collections of lakes of pus that we see in these patients. Now, once that happens, there is some crosstalk between the IL-36 pathway and a little bit of the IL-17-23 pathway. So there is some crosstalk where once we get that IL-36, we can start to activate some of these IL-17 genes. And so there's some overlap. And not surprising, some of these patients can have some concomitant plaque psoriasis that co-occurs with their GPP. But again, to drive home the point, plaque psoriasis, very IL-23, IL-17 driven. Mutations are very rare in the IL-36 pathway, very, very small percentage. Most of them are going to be in the IL-23-17 pathway. Again, very adaptive T cell driven. GPP, a lot of these patients, so almost half of these patients or so, can have these GPP IL-36 mutations. So what happens and we'll get into the mechanism here, but we're going to talk about the genetic component being very strong for GPP in the IL-36 signaling pathway. And then we're going to see that circuit be the main driver of symptoms. Now, when you talk about the underlying mechanisms, there's two ways we can get GPP. We can have dysregulated levels of IL-36, meaning high levels of IL-36, or we can have another component where there's a natural break for the IL-36 signaling pathway. This is the IL-36 receptor antagonist. So this is a natural endogenous break on the system. And in these patients with GPP, a subset of them are going to have mutations where that break doesn't work. So once IL-36 get turned on, body has a hard time to turn it off. And that's going to be one of the main drivers for these patients who are going to have this persistent dysregulated IL-36 signaling. But there might be other changes that are going to just lead to higher levels of IL-36. So they don't necessarily have to have the mutation, which is why we don't often do genetic testing for these patients, which are pretty rare relative to what we might see in plaque psoriasis as in terms of in the clinic every day. We probably one in about 100,000 patients have GPP as opposed to much more common frequency for plaque psoriasis. So we know that GPP is not driven by the same pathways as plaque psoriasis. We know that IL-36 is very central to their pathogenesis. And what was exciting about this story in terms of the translational immunology is that we saw that there were these differences, but then we have the development in the clinical trials of a targeted therapy against IL-36, which works very well. And this is a nice translational story because it really helps us personalize therapy to patients. We see there's a difference. We might see a little IL-23/17 signaling occurring in these GPP patients, but historically they haven't responded very well. And this is in contrast to spesolimab, which is basically an IL-36 receptor inhibitor. So again, giving that break to the patients to turn down the IL-36 signaling. We saw in the clinical trials these patients who even in 1 week had dramatic responses to intravenous IL-36 receptor inhibitor replacement. And that was really important for really driving this point home that GPP is truly distinct from plaque psoriasis. Therefore, our approach to treatment needs to be very different. So spesolimab, very targeted therapy against IL-36, works by blocking that receptor, blocking that dysregulated signaling, whether you have a mutation or whether there's just high levels of IL-36 cytokines driving disease. And our approach to these patients is going to be different than plaque psoriasis in that we have an urgency for these patients. These patients have widespread disease. They can have a lot of pain. They can have systemic symptoms. They might have fevers or arthralgias or joint pain. They often show up in emergency rooms or urgent care thinking they might have an infection. These patients often go misdiagnosed or underdiagnosed, and many of the plaque psoriasis treatments don't work well. So the approach now with a targeted therapy specific for GPP, the only targeted therapy for GPP is by giving them back that IL-36 receptor inhibitor to calm down that activated signaling. We do that in two ways. We have the intravenous treatment, which is going to be for those acute flares. These patients with GPP, while they have disease all the time and they have symptoms almost every day, they're going to have these periods of these acute sudden flares and worsening of their disease. And this is a good example of where we would use the IV formulation of spesolimab to really calm down that acute flare and get them back to a good baseline. But importantly, those patients, because even when we address their flares, we know that they're going to go on to keep having symptoms in between these flares. We then want to have that conversation about the use and need for a subcutaneous maintenance regimen where we can give this to patients, adults all the way down to age 12 that are at least 40 kilograms. They can have this subcutaneous administration where it's able to kind of maintain their disease in between these flares which is really important for them achieving a high quality of life and not having to live with this fear of when is my disease going to flare. So with the IV formulation, this is given as needed, administered 1 week. We give it as needed after that for these acute flares. Those are going to be the severe sudden presentations. That's going to be 900 milligrams. We administer it over 90 minutes. And then for those patients for maintenance who are not experiencing one of these acute flares, we're going to use the subcutaneous formulation, which is the loading dose at 600 milligrams. And we're going to follow that with the 300 milligrams every 4 weeks, as long as those patients need therapy. Very targeted therapy, a very successful story from translational medicine and personalized medicine, helping us tease out the unique immunology for GPP versus plaque psoriasis, and really choosing the right therapy for these patients with very high success, very fast response, and helping those acute flares, but also the long-term maintenance of the condition. Hope this helps in giving you a little primer about GPP and some of the unique therapies. Thanks.